So with that, I'm inviting our next session speaker today on costing of hemodialysis procedure. And to deliver this talk, I take great privilege to invite Dr. M. Prabhakar sir, who is also the organizing chairman for this event. He is a chief consultant urologist and transplant surgeon and managing director of Kalyani Kidney Care Center, Erode, Tamil Nadu. Dr. Prabhakar sir is a pioneer and expert with over 20 years of experience, and his commitment and emphasis towards quality health. Kalyani Kidney Care Center became the first NABH accredited hospitals in India. Welcome, sir. Over to you.
Again, once again, I thank the CQE and CAHO for giving me this opportunity and talking on this costing of hemodialysis procedure. I'll just quickly run through the few slides, which I don't want to really waste time on this. Actually, when we started analyzing costing of hospital procedures, it was actually the initiation taken by Nursing Home Board of Tamil Nadu with IMA, and we had a lot of difficulties in really formulating a formula or module by which we can do a proper scientific costing. Initially, we had a lot of brainstorming sessions with large, medium, and small hospital owners, and a cost auditor who was technically qualified and who was experienced in this field was also included in the team. But most of the hospitals, they proposed that the cost would be taken from different hospitals, and we'll take an average and put it as a cost for each procedure. But that was not scientific, because IMA wanted to every time go and fight with the government for the Ayushman Bharat or the state-run government insurance schemes, where the costings are done very low. And when we go and ask for them and they don't give an answer, there is no scientific methodology. So a committee was formulated by the Nursing Home Board of Tamil Nadu, which consists of the cost auditor, and I was one part of it, and another 7 or 8 people, doctors around Tamil Nadu, were involved in this. And we studied a lot of other modules which was done earlier, like Karnataka, the state government and Association of Healthcare Provider combined. They had done a study module, and some studies were done in New Delhi. We just took some inputs from them. But thing is, we were very particular that this has to be more scientific, and each and everything. Our aim was to just give this to the government, and then subsequently formulate a joint committee consisting of the government side representatives and the private hospital side representatives, so that we can each and every point which we have taken in the costing analysis should be justified, so that they cannot say no. So even if you go to the court of law to fight for the costing factor, it should be in a very scientific method. That was our aim, and the costing was done initially. Finally decided that we will be doing it for a 50-bedded hospital with 50% occupancy in semi-urban area, because you have a lot of variations. One, the metropolitan city has a lot of costing involved in the running of the hospital itself, and if you see a rural area, there the cost is very low. So there was a lot of disparity. So we just took a standard thing for costing for a 50-bedded hospital, 50% occupancy in a semi-urban area. And the components which were involved in the costing were accommodation cost, employee cost, administrative cost, commonly used ward equipments like the nursing station, chairs, BP apparatus and other things, and ICU accommodation, which means ICU bed charges, and ICU common equipments like the regular monitor and BP apparatus, stethoscope and other things, and OT accommodation, which means the OT rental, OT usage charges, and OT common equipments like again the boils and the standard equipments which has to be used, and OT specific instruments like if you are using a laser for stone disease, or you are using some laparoscopic instruments, or some sort of robotic surgeries. So all these things will be named as OT special equipments, consumables, medicines and implants, and investigations and professional fees. In the entire components which we have taken, only 2 things were not done in a very scientific manner. Example is the investigation charges and the professional fees, because there was not much time for us to really go into a detailed costing analysis on investigation charges and the professional fees. So we had circulated questionnaire to all the associations and the hospitals associated with Nursing Home Board of Tamil Nadu, and we got 250 hospitals with the questionnaire filled in, and with that we took an average of the rates involved in the investigation cost which they have mentioned, and similarly we have asked for the association like Orthopedic Association, Urology Association, Nephrology Association. We had asked for two major things. One is the pathway, that is the pathway for each procedure. For example, if the patient comes for a dialysis, for a maintenance hemodialysis, the patient comes, reports in the reception, and then patient is shifted to the dialysis department there, and how it has gone, how the pathway goes, and how is the patient kept post dialysis observation, and what all investigation is necessary before any procedure is done, and per procedure and post procedure. So this is a pathway which is defined by the particular doc, because this can be different from each hospital. Like for example, if a patient comes for a ureteroscopy procedure, I might do some investigations which may not be done by other urologists. So we got a common pathway written out by the associations, which again was they have received this common pathway through the member hospitals of that particular association, and then we decided on the professional fees. So these two things were taken on an average, but other things, the other components were done in a very scientific method. I'm just going to explain that. And like we took these as the guidelines, like Clinical Establishment Act, because that time Tamil Nadu did not have a Clinical Establishment Act way back in 2018. So we took the Central Act standards and Indian Public Health Standards, Minimum Wages Act of 2018 in Tamil Nadu, and International Patient Safety Goal, IRDA norms for billing. They have given clearly how a billing has to be done. So that was taken. And as I told, clinical pathway from associations for professional fee and other fees like this. So these are the standards which were taken into consideration, because, and one more standard is NABH, which I initially included in this, but most of them, the committee members rejected that, because if we put that NABH as a reference to this costing analysis, then the government will insist that every hospital has to go for full NABH. Only then this costing will be given. So that was the reason why, even though we took a lot of inputs from the NABH standards, but we are not quoting that as a standard which we have used for the costing. So the result which revealed out of this costing, accommodation cost, that is, the hospital could be very big or very small. Like as Dr. Prasanna told, for a dialysis unit, you can have a small room with too many beds put into that for a dialysis unit, or you can have a very posh area to fit in a few dialysis machines. So there is a lot of variations, so disparity. So we took the floor area required as per the CEA standards. So they have given clearly for a dialysis unit, for the bed, each bed has to be given this much area, as I think Dr. Prasanna had initially given those numbers. So we took that as a standard, and value again had a very big variation, because some hospitals were 40 years old and they have finished their debts, and their running cost was very low, and few hospitals are newly built with a lot of technology and other things, so they had put a lot of money in that, and loan and other things were there. So we were just really wanting to make it more scientific. So what we thought was, we took the standard as rental from a government institute. Like for example, in a semi-urban area, a government nationalized bank would have rented a building, or a police station would have rented a building, or some other government institution would have rented a building. So with that, we have taken some inputs from several semi-urban areas all over Tamil Nadu, and we have put that as the basic price per square feet. So this is the accommodation charges. So how much area is supposed to be there for an ICU bed, for each bed, or for a OT or a dialysis unit? So that is decided by the Central Act of Clinical Establishment 003, and how much to charge for each square feet is taken by the rent, as I mentioned before. So with this, it comes to 2036 for a general ward bed. I'm just talking about general ward bed. 2036 for a general ward bed with 50% occupancy. And then the employee cost again. This, how many employees has to be there for each thing. So that is decided by Indian Public Health Standards. And Minimum Wages Act 2018 was taken as a guideline for taking how much wages has to be given. Even though we have not implemented, we have got a court order saying that the government rates are very low, and until a committee is formed and these rates are revised, we cannot implement this 2018 Minimum Wages Act, which is huge. So that is how it is still pending. But with that wages as a baseline, it comes to 2,212 per bed for a 50% occupancy for employee cost. Then administrative cost is like all statutory licenses, taxes, etc., plus your bribes and other things, which you cannot come out openly. But this worked out to be 1,700 and odd per bed per day. And then comes commonly used equipments. Other than ICU, OT, you have reception area, you have insurance desk and other places. So that works out to be 246 per bed per day. OT accommodation. If the patient goes in for theater, then this will be the exact thing like what I said before. And then OT equipment. These are the basic equipments which are there as per the Central Clinical Establishment Act, which is mandatory for each OT to have it. And then comes the OT special equipments. So that again, the equipments which we bought for the theater or the hospital, that rate was taken from the purchase rate of the same product bought in the government hospitals in Tamil Nadu. So I'm sure it is going to be more than what we have bought it from for a private institution. For example, if we buy a cot for 10,000, government hospitals might have bought it for even more than that. But the same cot, same make, whatever charges the government has bought for, so we have taken that as a standard to charge the equipment charge. And ICU common equipments, again, this is the charges. And medicines, consumables as per the case. So for example, if you take medicines and consumables as per the flow chart, data flow, it is maintained as per the data flow. And we have taken only the purchase rate. It is not the MRP. It is only the purchase rate we have taken. And implants also again as per the purchase rate. So these rates again we compared it with the government hospitals rate. Drug consumables, implants were charged as per the purchase price, and as I told you. And the most important one, point I want to emphasize is single-use disposables. So this is one thing which everybody should be aware of, because in India the law says that we cannot reuse any disposables, which is mentioned as only for single use. But as compared with US or UK, there is an organization where they can give it for recycling and reuse the disposables as per their standards. But in India, it is not allowed. And Maharashtra, 2 hospitals were penalized for reusing cardiac catheters and like that. So this is a problem here. And for cutting cost, we are all reusing the disposables. Even in NABH, there are provisions where we have to clearly spell out how we are going to reuse, how many times we are going to reuse, and what are the method for cleaning it and processing for sterilization, other things. But as per law, this is not. So that is why we took disposables as a non-reusable thing, so that when we come and talk to the government or the court of law, we can say that this has to be, it will not be reused, it will be for single use only, unless they mention it that you can reuse it multiple times. That is the idea why we wanted to put it as full. And the blood investigations, I told you, we have taken these rates, and all the other fees we have taken from the hospitals I have mentioned. So with this is the outcome which we have come for a standard accommodation for a general ward, and ICU charges is 11,000 odd. So this was the outline of how we calculated. But with this, we made a template with the clinical pathway and the cost calculated as per the inputs. This is the template. Here you can see, like for maintenance hemodialysis, there are units like for consultation time, how many hours you see, OT time we calculate for this one, and how many days the patient has to stay. This is a daycare procedure, so there is number of days 0. So with this, you can see on the pharmacy cost, consumable cost, these are all derived as per the calculations which I showed before. So according to that, it is 3,822 per dialysis as a daycare procedure. So this is how we derived this. So this is one thing, and for initiation, like, see, if you see, some patients come directly to the casualty and we take them to the ICU. Some patients are very stable that we keep them in the ward. But on an average, we took patients for 3 days in ICU and 5 days in the ward, with 3 to 4 dialysis after initiation, with central line and other things. So that worked out with this calculation as per the details which I quoted before. It worked out to be 89,654 for hemodialysis initiation. This doesn't have a profit margin at all for the hospital. So this is just the cross price and the basic cost which we have to charge for the patient. So this is, I think, so this actually was done in 2018. Now it is 2022. So the present cost will be more as per the inflation rate. Thank you.
Thank you, sir. Thank you once again. Healthcare and its services should be high quality, affordable for all, so that a maximum population can benefit from it. Hence, your talk was paramount importance, and we hope it will pave way for high quality and affordable dialysis services across our nation. Thank you once again, sir.